Hello, Harshad.
Hi, John.
How you doing?
I'm doing well. How are you?
Very good. I'll tell you, you
Yeah.
must be going for high marks because you're sitting in the front row and you're first one in class.
I'm always trying to be first row.
Yeah, that's great. So,
Great, great.
so you're in the hospital now?
No, I'm not in hospital today. Sunday, Sunday
Oh, that's right.
evening.
Okay, okay.
Yeah.
Yeah, different countries or
Yeah, I understand.
take Sundays, Saturdays, different days, whatever. But okay,
Yeah.
I'll be back. We'll be starting in about 55 minutes.
Okay, I'll see that. Okay.
Okay,
Yeah, thanks. Bye.
sure. Greetings, Lima.
Hi, Dr. John.
How you doing?
Good, thank you.
How are things going? Where are you, in Beijing?
Yeah,
Oh, okay. Yeah, you're giving it. You're not giving a talk today, right?
yeah, I'm not giving a talk today, but Professor Yuanli Zhao,
Oh,
might
good.
be
Oh,
absent.
great. You just came. Great.
Yeah.
Great.
Yeah.
It's now you're in Beijing. Are you at Tiatan Hospital also?
Yeah, I'm working in
Okay, with
yeah.
Wan Li, the same hospital?
Yeah, exactly the same.
Oh, okay. So you guys know each other.
Yeah.
Big, how big is, but the departments are big there. How big is your
Yeah.
department?
We actually have 596 beds. So it's a really large hospital. And we actually have 170 neurosurgeons actually as staff. So that's really big. But
Wow.
China has a great population.
That's a
So
little
that makes
city.
sense. Yeah.
How do you guys communicate? I mean, you guys have a very advanced website of neurosurgery videos. You know,
Yeah, we
I
have
think they're
a
much more advanced than we are,
uh,
and more organized. But I guess you guys participate a lot in MedTeon. Do you participate in that, or do you have your own platforms that you use within the hospital?
you mean for the video share or something?
Yeah, for like conferences on video.
Actually, we have a kind of apps.
An
Yeah,
app?
yeah. It's organized by a certain kind of a company in Shanghai, actually.
Oh, okay.
So usually most of the conference notice would podcast through the apps. And
Oh, okay.
yeah,
Makes
the
it easy,
neurosurgeon,
right?
yeah, it's easy for the neurosurgeon from other places. They can just log in and yeah, check everything what's
Okay.
going on all
Can
around.
you put in the chat the name of that app, please?
Let me see.
It's not the WeChat app. I have
Yeah,
WeChat.
WeChat is kind of online apps, just like what we call in US.
Oh yeah. I know about WeChat. I don't know how to use it very well, but you know, they have the video. They have video. You can televise on WeChat, right?
Yeah, WeChat is kind of Instagram.
Okay.
Yeah,
Okay.
that's not an for the academic meeting. So let
Okay.
me see.
That's pretty public.
Yeah, and the apps for the let me see. It's called mediton.com. It's spelled as MED.
Okay, let me write it down here.
TION. Medicine.
What is it again?
It's medicine.com.
MAD
MED.
NED. Can you write it?
MEDTION. Yeah.
NED
TION.
TION.
Yeah, MED for medicine and
Oh,
TION.
MED, Medtion. Yeah,
Medtion.
Medtion. Yeah, Medtion. Okay, they have an app.
Yeah.
Oh, okay. Yeah, they have a big archive of videos, huge archive, right?
Yeah. So it's a company that's also known in the US or somewhere.
Yeah. No, I know about them. We're being televised on them now.
Ah. Okay. So yeah.
And I'll show you. I'll screen share once we start. Of course, we haven't started, so I don't think they're televising this part. Let me go to Medtion. I didn't realize I had an app. Okay. And I'll screen share this so you can see it. Okay. There we are. You see the mention,
Yeah.
see this? Here we are, right here.
Yeah, that's exactly.
We actually, I don't know, they may have us on live now.
Uh-huh. So actually they have,
Yeah, there we are.
the one we have.
Yeah, so, yeah, that's great. Metion as an app. I'll download that. And
So
try to
it's
figure
here.
it out. I'm sure it won't be too difficult. Change my background here. Good morning, Zanab.
Yes, sir. Good morning.
When you gonna get your camera?
It's not working.
No, it's not working now. It'd be good for, for people, well, if you can, I know that sometimes you can't because of bandwidth problems. But it'd be good to get to know your face.
Okay, sir. I will check for the option. Right now, I can find it here.
Because someday you're gonna be looking for residency spots.
Exactly, sir.
So if you knew these people and knew your face, it's a lot different than just an email.
I agree, sir. I 100% concur. So what's the time in the US right now? You woke up so early.
Right now it's 8 o'clock in the morning.
That's
8 o'clock
Eastern
at night
time.
in China.
Okay.
So Lee, you specialize in cerebral vascular?
Yeah.
Okay. Is it like a fellowship or your residency or?
I have graduated from the neurosurgery residency 5 years.
Oh,
So,
okay.
yeah, but still in general practice, also in some other specialty.
Oh,
Yeah.
okay. So is like a fellowship or something like that?
Yeah, kind of equal to the fellowship in the US.
Oh, okay. But I'm sure you have lots of work, right? It's probably more work than you need, right?
Kind of.
Yeah. Yeah, seems that most neurosurgeons are busy no matter where they are.
So actually, I'm completing my first part of my residency next year.
Oh, okay. Yeah, sometimes
And
when the internet is not good, it really doesn't give a good picture.
yes, sir. And I'm thinking of a
So
place where to go
how
and
are
do
things in
fellowship.
Africa?
I'm currently in Moscow.
I'm sorry?
I'm currently in Moscow.
Oh, Moscow.
Yes, sir.
Oh, wow. You weren't there last time, right?
Yes, sir.
Oh,
I
okay. I
came
didn't
here in 2019.
Oh, okay. Okay.
I will be
So-
completing my first part of my residence next year, and I'm thinking of a place to continue.
Well, you got the internet to explore and check out, talk to people. Best way. And conferences like this are a good way too. And just ask people.
Yes, sir.
Because I've seen people get spots by talking to people. That's how it starts. Lee, are Chinese neurosurgeons starting to go back to conferences, or are they still doing a lot of online?
You mean what?
Are the Chinese neurosurgeons going to conferences, leaving the hospital and going?
No, they can just log into the apps and wherever they are, and so they can access to the meeting through the portable devices.
Oh, great. Great. Here, Vlad is coming. Vlad is here.
Hello, John.
Good morning, Vlad. How you doing?
Hello. I'm doing fine. It's not the morning, early afternoon.
Yeah, it's morning here. It's morning here. I'd like to meet Lee. Lee Ma, he's a cerebral vascular fellow from Beijing Tiatan Hospital.
Right.
Hello, Mr. Vladimir.
Hello. How are you?
I did good.
Nice meeting you, actually.
Yeah, I still remember at 2017, I guess. It's
Sorry, I got the phone. Sorry.
Right. Oh, here's Ben. Good morning, Ben.
Hello, John. Hi,
How are you?
fine.
Lee's here
Professor
and Vlad's
Bennett.
here.
hello, Professor Xu.
Hi, Mali.
Hi, Ben.
Hi.
How are you?
Bennett. Fine. How
Good
are
to see you
you?
again.
Yeah. Good to
So
see you.
Vlad, where's the study? You're not in the study now. Yeah, with
Which
all the
study you
books in the
mean?
back, with all the books in the back.
About what?
You're usually telecasting from your study with all the books in the back.
This is not the home. This is my study.
Oh,
This is
okay.
my
I don't
office
see
in
that.
a
Oh, okay.
hospital.
Yeah, okay.
See?
It's a different view. Okay.
Mhm.
Different view.
Different
not the
view. Yeah,
books
because
and,
usually you can see that big bookcase there in back.
Right. I'm at the hospital, not at home now,
Oh, okay.
Ah,
which is just the same thing. Close. 10 minutes drive.
No, Vlad, you've been to China, right?
Many times.
Many times.
15, 16, 17 times probably.
Really?
Part of it collecting pictures in the past when it was still possible, not anymore. And half of it like professional, you know. Beijing, Tianjin,
yeah.
Chengdu, Shanxi, whatever.
Did you know Ben there? Did you see Ben there?
I don't know whether we have met Ben. Did we?
Okay.
No, I don't think so.
Oh, okay. Okay, we got.
John
Yes.
or Ben, how is it going to be translated? Should I speak slowly or can I talk in normal pace?
It's just in your normal pace. Yes, no problem.
Okay.
Mm-hmm.
He still speaks at the normal speed, right?
Mm-hmm.
You know, yeah.
Normal speed.
They seem to be good translators. And Victor's talk went well, Ben.
Yeah.
Yeah, it continues to get a lot of viewers. It continues, continues.
Yes.
And we can track, as you know, we can track that.
Yeah.
So when the Westerners do videos, I'll be sure to say they have a long shelf life, what's called a shelf life for a video. In other words, how long is it going to stay there and have staying power and have influence? Do you know what I mean?
Yeah.
Yeah. So I think that's valuable in itself.
Yeah.
Okay, I'll be back in a few minutes. We start in about 6 minutes.
Recording in progress.
And I've done clipping, which is disastrous sometimes, as you know, to coiling with recurrence, to onyx when there was onyx for annual.
Hmm. No, no, Vlad, I've got to come to Kafka's home. It's on my bucket list for sure. I gotta come to Prague.
John, do you have any idea how many webinars did you have through you?
A couple of thousand. We got a couple of thousand.
Couple of thousand.
Yeah. Yeah.
Time consuming, isn't it?
Yeah, but it's fun. It's fun.
It is.
It's enjoyable. I'm sure you guys would enjoy it too. If it came
Yes,
to
of
that,
course.
maybe if you know, you got injured or something.
Yeah, it's very enjoyable. And actually, that's the only positive side of COVID.
I'm trying to get these videos off here. Okay. There you go. I guess Juan Lee, maybe, Ben, do you want to start or do you want to wait till Juan Lee comes or? Can't hear you, Ben.
Yes, we can start.
Okay. Okay, very good. Okay, here we go, Vlad. I'll introduce you. No, who should I introduce you first, Ben?
You're not audible. You have to unmute
And you introduce Vlad?
Yeah, actually, I can introduce Professor Bennett.
Okay.
So
that's a-
Bennett is the first speaker.
Okay, I'll introduce Vlad.
Okay, okay.
Yeah,
Okay,
because
no
he's
problem.
first, right?
Yes, I
Okay.
asking.
Here we go.
Professor.
10, 9. Okay, turn your videos off if you have any videos. Because I'm hearing a video now. Someone, let me see here. Before we start, I want to make sure it's right. Okay, Vlad, you're yeah. Okay. Okay, here we go. 10, 9, 8, 7, 6, 5, 4, 3, 2, 1. Good morning from Miami Beach. This is Dr. John Bennett broadcasting from the home of Neurosurgical TV, Miami Beach. We have the 9th edition of the Chinese Neurosurgical Journal webcast. And today we're featuring Vlad Bennett. Now, I'm not a neurosurgeon, but I've been doing these webcasts a while in neurosurgery, and Vlad has certainly contributed to the general, you know, updates. During the pandemic, we did like 60 webcasts. I don't know if Vlad probably doesn't remember, but he did a lot of them because we did daily webcasts during the pandemic, and he came to the fore. So, okay, I'd like to do, okay, Vlad, it's all yours.
Yep, ready. Let me share the screen.
Not yet.
Not now. Something went wrong.
Okay, Vlad, you're on mute. Okay. Yeah, make it presentation mode. Oh, can you hear me, Vlad? You're on mute. You'll get it. You're just hanging there. Okay, that's it. Start again, Vlad. Can you hear me, Vlad? I think he may. Okay, Vlad, you hear me, right? Oh. You're on mute, Vlad. You're on mute. Okay. We're getting there. It's at the bottom, Vlad. Sorry about this, folks.
Okay, is it okay now?
Not yet, Vlad.
Yes,
You need-
yes.
You need,
Yes.
you need,
Okay. Very good. So let me please start. I'm sorry for the troubles at the
no,
beginning.
that's
but
okay,
I
Vlad,
somehow-
Vlad, you need to put it on presentation mode, so it's full size. Do you know
It
what I
is full
mean?
size. On my screen, I
Yeah.
have a full size.
No, it's not. On our screen, it's not. So
Is it?
go
So
to the
again-
bottom of the screen. There's one of the options at the bottom of the screen. One of those options is for presentation mode.
I know. I do it as
Not
always.
yet.
Share.
Okay. Okay.
You don't see the screen properly?
Yeah, but it's not correct. It's not correct. It's not correct. at
My
all.
screen, I have the presentation, so I shall skip the presentation and I shall
You guys don't see the right screen, right?
get the new share.
No, Ben, you don't see the right screen, right?
Yes, we can see the computer screen, but not the slides.
Now,
Not
My-
really. Can you start again, Vlad? Please start again. Just start again.
I can. This happened
Oh,
to me
okay.
several times by now. So let me start from the beginning again.
Yeah. Okay, just start again
I do.
and we'll take
Screen
it
sharing
through.
has stopped. The chat window is closed, so I
Yeah,
open it
yeah.
again.
Yeah, start it and we'll walk it through, okay?
I will.
Okay, take your time.
Now the presentation got closed, so I must get. I'm terribly sorry for this. So let me
It's okay.
open the
It's all right.
presentation. Ooh. Now I do not even see the Zoom. John, how is it now?
Open the PowerPoint up. Don't go to the Zoom, go to
It's
the
open.
PowerPoint.
It's
Yeah.
open, but I'm not seeing the.
Yeah, you're not sharing the screen.
Wait a minute.
So you
I
need
have
to
an
share
idea.
the screen.
What
Yeah.
I'm doing wrong. That's it. So share screen
Right, share screen, and then go to your PowerPoint.
again. Now there
you
is the
go. There
PowerPoint.
you go.
Do you
Okay,
see
now
the
go-
PowerPoint? And now I'm
Okay, but it's
switching
not the
to
right
the.
size. Okay, you need to go to the bottom of the screen to pick one of the options to make it full. There you go, at the bottom.
We go.
One of those options you gotta click.
No. Is it all right now? On my screen, I have the presentation mode already.
No, it's not showing to us though. It's not showing to us.
What I'm doing wrong?
Well, because at the bottom of your screen, there's an
The
option to go
bottom
on.
is share screen. All right, I hit the share
Yeah,
screen.
that's right. Go to share
Now
screen again.
it opens and I see the presentation. I hit the presentation, isn't it?
Yeah, but we're not seeing the correct size, so you have to go once again to open it.
I'm going from the very beginning.
Okay. Maybe you guys have a different take. Okay, click on one of the slides. See what happens if you click on one of the slides.
Do you see the presentation now? But not the presentation mode. Am I right?
Oh, but yeah, we're not seeing it though, unfortunately.
Yes, we can see your computer screen, and you
Right.
just put
All
the
right, so
play.
I go
Yeah.
to presentation mode now.
Okay,
Now, my
Okay.
screen, everything so seems all right. What's on your side?
I guess we can go forward, right, Ben? What do you think?
Yeah. We can
Go forward, Vlad.
Yeah.
Go ahead. Let's try it. Let's try it.
So sorry for this. I hope that the presentation will be all right.
Okay.
My topic is supratentorial. There is some noise. John, there is some additional noise in the background. Okay. My topic today is are supratentorial meningiomas. I have nothing to disclose. In the lecture outline, I'm going to talk about the skull-based surgery and cerebrovascular surgery, which is a different topic actually. I'm going to talk on arachnoid and cisterns, olfactory groove meningiomas as an example, then taxonomy of the skull-based tumors, and of course, convexity. Then I shall go through respective areas, tuberculum, glinoid, middle fossa, pioneer, convexity. And at the end, there will be general remarks. And I hope that everything will work. All is based on 20 years experience with meningioma, with some 1,800, out of which 860 were skull-based, dominated by wing and glinoid, followed by olfactory and tuberculum. So let's go to vascular versus skull-based. Vascular, the model disease are the aneurysms. In skull-based, those are the meningiomas. And actually, we are in completely different space.
Excuse me, Vlad, it's not going forward. The slides need to get, you need to go forward. We're
What
just
should I
seeing
do
your
when my screen is just working properly?
Yeah, we're seeing the first slide right now. That's it.
So once again, I shall stop the presentation.
Well, there's no, just click there, click on the next slide. There we go. We see it. We see it.
You see it, but not the
Yeah, we see
presentation
it, the
mode.
vascular aneurysm.
Right. So now I switch to presentation mode, okay?
Yeah. That's
You
it.
see
That's
it?
it.
That's it. Very good. So we are talking aneurysms where we operate in a subarachnoid space. We cut the arachnoid and we open the cisterns. This is just the opposite in meningiomas, where we should stay extra arachnoid. We just lift the outer arachnoid membrane and preserve the arachnoid. So those are completely different spaces in which we do the surgery. See the aneurysm surgery, hold the vascular T supratentorial is exposed from one basilar artery, one P1, the other P1, the opposite side come the carotid, middle cerebral, anterior ACOM complex. All this can be dissected subarachnoidally. We can pick as many clips, as many aneurysms there are from one single approach, just going through the subarachnoid space. You see it here. The membrane which I'm picking off the aneurysm of the ophthalmic artery, this is the optic nerve, is the membrane which is wall of the carotid system.
Vlad, I'm sorry to interrupt you again, and I'm sorry to do it. Well, we're still staying on the same slide, unfortunately. Go to the bottom where you're at and try one of those options. Remember, you were at the presentation.
I have the finished presentation. Okay, so let's go backwards.
No, at the bottom of the screen, you were there before. I think we got to poke
do you
around
see
there
the
a little bit.
angiography now? Do you see the angio?
No, right now we're looking at the vascular slide, vascular aneurysms.
This one.
Yeah, it's the first one you saw. So let's try go to the
What
bottom
about
of the
now?
screen.
Did it move? Did it
No,
move?
it didn't move.
How can I move it?
It's not moving. Try to go to the bottom of the screen, Vlad.
At the bottom of the screen, there is backwards, forwards, finish presentation.
Yeah,
enlarge
the next to the
something.
present, there's a couple of options beside the presentation.
Let
Try
me
try
this.
the other ones.
What about now? Did it
Because
move?
it's not working, obviously. Are you
I
seeing
don't
those
know what to do.
options?
Because I have everything all right on my screen.
Yeah,
And I don't know how to
but
how to
try
manage.
it again at the bottom, because we're not seeing the
Okay.
changes at all.
Tell me if the slide changes. No? No?
Well,
Where
maybe
is-
you guys can explain better than me.
I think Professor Vladimir, maybe you can try when you share your screen. There's a kind of desktop and the PowerPoint,
Is there?
and you can maybe try either one. So
So let me finish the presentation again. I'm still on that vascular slide. And now I should go to presentation mode.
maybe it's a problem due to the screen share.
Now I have the presentation mode.
Yeah,
must
maybe you
be
can
some-
close
Your
the
screen.
slide right now and try
I
to
click
see.
sharing.
Yeah,
Let
the
me
screen
share
share.
again.
Yeah, when you go to
Do you
the
see my screen with share? Here is the lecture, meningiomas.
Not
Hit it.
yet.
I share. Do you see the screen?
Okay, actually, maybe we can just in this mode. You can.
Those
No,
star
no, no.
videos. Let me one second go to this one. Do you see my screen properly now? The vascular versus skull base
Yes.
slide.
Yes, we can see it.
I moved forward. Can you see the surgical image? Or is it
Try
still
to
the-
move forward. Let's see if you can move forward.
I'm moving forward.
Okay, we're not seeing that though, unfortunately.
So let me do it this way.
Okay, at the very top, there's a,
Okay.
Okay,
yeah,
now
it
it's
finally
okay.
moved.
Yeah.
The only
Move.
way.
Can you see
I will
it
move like
moving,
that.
Vlad?
So I was talking about the subarachnoid space and about the extra-arachnoid space. This is the aneurysm surgery where you can dissect everything which is there, from basal to acom to opposite side middle cerebral. Just dissecting the subarachnoid space, you can apply as many clips as there are aneurysms. In this case, there were 5, even the opposite side and 1, 2. So this is the intra-arachnoid surgery, subarachnoid surgery. I hope the video will play this way. It does. You see now this is the ophthalmic artery, the optic nerve, and the arachnoid I'm trying to get out of the aneurysm is the wall of carotid cistern in which the aneurysm is located. You should preserve that because this arachnoid covers the optic nerve and preserve its vasculature. Let me show you what it looks like after that. The whitish on the optic nerve is the arachnoid, and you see the well-preserved vasculature of the optic nerve, and actually vision really improved after the surgery, after this decompression. So this is extra-arachnoid. Just the opposite is true for meningiomas, which are extra-arachnoid. See this image? This line is the arachnoid of chiasmatic cistern, which is lifted from the skull base. You see the tumor here. And this is after the resection where the arachnoid of the chiasmatic cistern is preserved. Thus again, the optic nerves are covered by the arachnoid and not harmed. Let me show it to you on the video. This is the glinoid meningioma, but this is the true surface of the meningioma. This is the arachnoid of carotid cistern. As long as the meningioma is smooth and shiny, it's covered by the arachnoid. Actually, the surface of meningioma is rough and pinkish. This is the proper plane of resection, which we must keep. This is why I'm talking that much about the arachnoid, and I will be talking about it even further. You see, 2 olfactory groove meningiomas differ in 2 respects. One respect is the edema. In this case, it's only on the right side. In this case, the edema is bilateral. In this case, the anterior cerebral arteries are moved to the side. In this case, they are in the midline. What does it mean graphically? Whole the left side, including the olfactory system, are covered by several layers of arachnoid. Just you have the pain of dissection and you easily preserve them, and you preserve the smell. Not in this case, where everything's covered only one single layer, which easily can be penetrated either during surgery or by natural behavior of the tumor. This is what it looks like. Again, small olfactory group meningioma, and coming from the side of the tumor, there is always some asymmetry. Easily preserve the opposite side olfactory nerve. It's much more difficult to preserve the ipsilateral, but contralateral may be preserved. And of course, the smell is an important sense, and you would like to preserve it, like in this case of planum tumor, and you see the whole olfactory nerve being dissected free. We published that actually in patients with olfactory groove meningiomas who came in with some preserved smell, we were able to preserve the function in 70% of them. So it's really worth preserving the function. It's all about the arachnoid system, the skull base, and even at the convexity, it's about arachnoid. There are not many anatomical studies on the system. This is Roton, in whose book there are systems, and you see what they look like. Unfortunately, they are like really divided spaces. They are not. There is this study of Kuruc, and you see that there are no walls. Only the outer wall is firm and impenetrable. The rest is like, say, only curtains with holes, with all the disconnections, holes, because the CSF must work somehow. Here we go for studies in Tours, where there is excellent anatomical laboratory. We dissected several brains there. Then I sent one of my residents there, and she published this article, which is really excellent methodology, how to dissect the base of the brain and how to preserve the arachnoid. And you see what we are getting. And it's already here about the spaces. Only the Lillienquist membrane, which is here anterior, is very firm structure and impenetrable, actually. You must put it together, CSS flow. Here is the open carotid system, which is also rather firm space. You see the third nerves. And this is what I'm talking about, that all the rest is like sustentacles or trabecules or many openings. This is the edge of tentorium, this is the third nerve. So here we are dealing with carotid system. Going backwards, we see the ambient system and crural system, and down there, interpenincular system. And you see the arachnoid, which is not like a wall. It's always just a strand. You may use them as your landmarks during surgery. You should be able to see them, but do not expect to meet the firm wall which would lead you. So in skull base, in meningiomas, it's about the arachnoid and system. So planning the approach with advanced knowledge of system and expected arachnoid layers, where the outer layer will be moved. Of course, the exact tumor origin must be defined. For this, we have images defining in which system we are doing our jobs, what structures are within this respective system. If possible, one should stay within one system. Unfortunately, not all tumors are single system. There is the concept of single versus multiple system tumors, and this is what I call system-oriented meningioma surgery. This is the table which is the courtesy of Pablo González Lopez from Alicante. Here we have the system, we have arteries which are in each system, vein which is in each system, and nerve, cranial nerve which is in this system. It's very helpful because you can refer to that all the time. And this is the example how to use this concept. You see a small tentorial edge meningioma. The problem is not the brainstem. The problem are the systems. where we are going to be. This is exactly the anatomical place of the tumor. You see the ambient system with the fourth nerve. You see the crural system with vein of Rosenthal and distal choroidal artery. And this is the surgical image just after the surgery. You see the fourth nerve and you see the Rosenthal vein, all covered by the arachnoid. Actually, this was very easy tumor to resect and very safe tumor to resect and very nice tumor to know everything in advance. Nothing was really much moved. What we do have are several classification systems and they are virtually the same. I'm going to show you only Yashargil and Almefti because they are virtually identical. Yashargil has midline tumors, which is olfactory groove plenum and tuberculum. Then paramedial, which is anterior glinoid, throws apex and cavernous sinus, and then lateral. And see that actually the same classification system is Almefti, who's got central tumors and peripheral tumors, but actually the classification is the same. The trouble is that the locations frequently overlap. So sometimes you have a plenum meningioma, which looks like tuberculum because it reaches back to the chiasm and anteriorly to the olfactory groove. So those are the tumors where you have really overlaps, and sometimes the series from the literature are difficult to evaluate. So let's start with tuberculum. Meningiomas, this is the typical one. You see it, and this is after surgery. Here we are with the anatomy, the opening of the chiasmatic system, which is not done during the surgery. And this is the chiasm. And here we go at the end, both optic nerves, and you see the arachnoid of the chiasmatic system, which is preserved, just preserving all the structures which are there. Let me show you some surgeries. This is a small one, tuberculum cella, and I came from the ipsilateral side. Now I'm not doing that. Always asymmetry, always coming from the contralateral. This is rather old video, but you'll see the problem which lies underneath the ipsilateral optic nerve, where the manipulation is sometimes difficult. And in this case, the tumor origin one goes directly underneath the nerve. And you will see the rather excessive manipulation just now, getting underneath the nerve and trying to reach the tumor origin. You see that the optic nerve must be lifted, manipulated, then even the residual tumor is approached between the optic nerve and the carotid artery, which is quite a lot. See what it looks like if it's from the contralateral side, which I'm now getting. Here is the drilling of the contralateral optic canal, and you drill the canal from the side of the tumor. You drill the canal where the tumor remnant will be. If you would be doing this in the ipsilateral side, you do not come to the tumor directly. You see that the remnant of the tumor, this is the optic nerve, is directly visible with minimal drilling of the opening. This is the contralateral carotid artery, which is nicely exposed in this approach. And here is the ipsilateral optic nerve, which is dissected from the tumor very early in surgery. And you see the tumor remnant being easily removed with minimal drilling of the optic canal. Actually, I drill the canal almost in all patients, especially the young ones. So concentrics for tuberculum, contralateral, frontolateral approach. Some 20 cc with lumbar drain and opening the carotid system to release the CSF, leave the optochiasmatic system outer layer and keep outside, stimulate the tumor origin, detach the tumor from skull base, decompress, remove the suprasellar part, then open the optic canal on one or both sides, depends. The younger the patient, the more you want to be radical, and then at the end drill the tuberculum. Let's go to the glinoid tumors, which are rather frequent. Here's such an example of the glinoid tumor. And this is not the encasement of the carotid artery. You see the tiny black line coming from medial side to the carotid artery. That is the wall of the carotid cistern, and it means that the carotid artery will be enveloped.
Good morning, John. Thank you for the invitation.
Okay?
I'm sorry.
Thus, you will be able to dissect the carotid free, the anterior lobule of the tumor, posterior lobule of the tumor, and this is after surgery. You see the arachnoid of the optochiasmatic system is preserved, not at all harmed or cut. And this space where the tumor used to be is the outer layer of the carotid system pushed backwards against the Lillian membrane. All is preserved, and the only structure which really is released from the arachnoid is the carotid artery, nothing else. There was the single cistern tumor. This is the multicisternal tumor. This upper and anterior part will be in the cisterna lamina terminalis, and see what it means. If you know that in advance, you easily can get there. You do not overlook this part of the tumor. We are above the A2, dissecting free the lobule of the tumor, which is lying supracellary, and this is the lamina terminalis, the optic chiasm, and you easily remove the tumor. This is after the surgery. Being in glinoid, this is Almeftis classification. We have 3 types of the tumor. Type 1 is the most difficult one and most dangerous one because it's in carotid cavum. These tumors tend to be small because they very early on press the optic nerve. Then type 3, which is medially, again small tumors because they again push on the optic nerve. Then the dorsal tumor, which tend to grow larger because there is no important structure in their way, so they may grow to larger. And I would add the 4th type, which is on the lateral side, growing into the middle fossa. These are in anterior fossa, and those lateral ones are growing into the temporal fossa. And you well know that all these glinoid and meningiomas do have more temporal preponderance than the frontal. This is from our dissections because Almefti claimed that there are 3 or 4 millimeters of which is not covered by the arachnoid as it enters the dura, and this is the dangerous part because as soon as the tumor is in such a space where there is no arachnoid, it becomes very invasive. And see that it's true. This is the distal ring. This is the ophthalmic artery, the carotid artery. We are looking from below. Don't forget that. And the arachnoid is only here. So all this space is not covered by the arachnoid, and that is the space where to be extremely careful during the dissection because it's very easy to harm the wall of the artery. Let's see 3 cases. 63-year-old visual deficit developed over 5 months. You see the tumor, not a large one. And this is the surgical video. The approach is very identical. Orbitomeningeal band being cut. The wing is drilled. As far as the anterior glinoid process, is the plane between the outer layer, dural layer of cavernous sinus and temporal lobe is separated. And then again, the orbitomeningeal band is released and cut. And then we go for extradural glinoidectomy at the beginning. This is the optic canal. What I do in cases of meningioma, not though in my aneurysms, that in quite a lot of cases, I do not remove the glinoid. I just break it free and I leave the tip behind because, and you will soon see it, I do not know the relation between the tumor and the glinoid. Here we are already intradurally releasing the tip of the glinoid process at the end when I don't know what it looks like. And then releasing the optic nerve, which is over here. And it's quite horizontally looking since it's pulled by the tumor, the outer dural ring. being now cut, thus exposing the carotid artery. The whole of the tumor is still in place, it's not released. You see the optic nerve being released. Here is the optic nerve, this is the ophthalmic artery, still the arachnoid is preserved, and only when the tumor is detached, it is removed. And here are the structures: optic nerve A1, carotid artery M1, this is the Heubner's artery, this is the A1 on the ipsilateral side, and the resection is really radical. This is after surgery. This vision improves. She has a partial third nerve palsy, probably due to heat from the coagulation. Another is 31 years old patient, visual deficit during pregnancy. We all know that the meningioma deteriorate during pregnancy. So she delivered a baby. We were able to keep her without any progression. She's otherwise completely normal. This is her tumor, and see what it looks like during surgery. That's why I do not get the glinoid process extradurally completely, why I only break it free. In quite a few cases, I leave it behind. Again, the distal ring, and the tumor is underneath the distal ring. And now the distal carotid, the carotid distal to the tumor is released. Here is the optic nerve, and here is the proximal carotid artery, and the tumor is so firmly attached to the wall of the carotid artery that it was literally impossible to release it. It grew into the wall. Now I'm cutting the tumor. Here is the carotid, here is the tumor, here will be the optic, and you see that it's bleeding here. So from this point, the tumor vasculature came in, and that is why I'm not that aggressive extradurally, because I would be unable to move that. This is the tumor removal, the main bulk of the tumor. And now you will see how the carotid artery is very intimately affected by the tumor. Here is the carotid, here is the carotid, and here is the tumor. It is so firmly attached to the wall of the artery, I had to leave a little tiny piece of the tumor behind. And after surgery, this is the patient, vision returned to normal. And here is the last female, Glinoid female 52. And this is a tumor, very small one, growing virtually in the carotid cavum. So it's completely extradural tumor in a way. You may use the navigation, but it's not really that useful because we are in the spaces we all know well. And again, the same approach. And now this tiny structure here is the optic nerve. So the optic nerve was completely enveloped by the tumor. We are drilling some more of the optic canal because the tumor extended very much into the optic canal. And now I'm releasing the part of the tumor which is lateral to the optic nerve. The optic nerve is here. The tumor which was covering the optic nerve is already released. So here we are between the carotid artery and the optic nerve. The brisk bleeding we are seeing there, I saw that I harmed the ophthalmic artery, which surprisingly was not true. The bleeding later stopped spontaneously. It was not a really nice place. So now it's being stopped by clip and some cotton. And we are working on the medial side of the optic nerve. You see that there is still the tumor there. Let's go forward. Now we are back. There is the clip which already holds nothing. This is the ophthalmic artery, which is well preserved. And this is at the end the optic nerve. And you see the arachnoid layers of carotid and chiasmatic system. And this is what it looked like at the end. Here is the arachnoid preserved. Here is the arachnoid preserved. This is the chiasmatic system, and this is the carotid system. Here is the carotid nerve, and this is the relevant anatomy to that. post-op CT showing the extent of resection, post-op MR showing the absence of the tumor. And due to the manipulation, the vision deteriorated, but in 3 days later, she counted fingers very nicely, and by 2 months, she was completely normal. Tips and tricks here, perional rather than frontolateral, because it gives you more angles of approach. Detach or remove the anterior glinoid extradurally, stay extraarachnoid, open dura from middle to the optic nerve. That starts is the same as in the ophthalmic aneurysm. To the tip of the glinoid, don't go on the lateral side because there is the third nerve, the dural ring, ascertain the tumor origin, and exclude that it's so firmly attached to the carotid artery as I've shown you in the second case. Detach the tumor optic sufficiently, the carotid canal, the optic canal. These tumors really tend to grow into the optic canal, almost all of them. Remove the tumor, plug the cavity after the anterior glinoidectomy. Let's go to the middle fossa, but we have covered it by these tumors because the middle fossa virtually is the most frequent site of meningiomas, because part of the middle fossa is sella, tuberculum, glinoid, and pyramidal apex. You see that the tumors grow mostly on the border of these fossas. It's actually the angle between the petrous bone and between the sphenoid bone, between the both glinoid processes, and going along the tuberculum sellae. So that's the largest space within the skull, and why the tumors grow there is easily explainable by the sinuses, because in the vicinity of sinuses, the arachnoid cup cells, which are origin of meningioma, are the most frequent. So we have this angle between the sphenoparietal sinus, cavernous sinus, and superior petrosal sinus plus intercavernous sinus, exactly the tumor we've been talking about. Unfortunately for us, this is the most difficult and most complex anatomy in the human body. This is the Roton's picture. The approaches to the middle fossa are numerous. The working horse still is the perional or frontolateral or whatever, to the anterior portion, to the glinoid area, and anterior part of the middle fossa, then subtemporal, which is a nice approach for certain tumor. Those petrosectomies are possible, but I really must admit that I do not like them, because in my hands and feeling, the approach is more dangerous than the tumor removal. And then you can come from posterior via supracerebral, infratentorial, transtentorial route, and you can reach all the midline structures in the middle fossa, which is a nice approach. So we've covered tuberculum and sphenoid wing, which would belong into this part. We have cavernous sinus and Meckel's cave, tentorial edge, and middle fossa proper. Superior petrosal sinus, its upper pyramid surface. A majority of the tumors from superior petrosal sinus area do grow into the posterior fossa, but there are the rare tumors which grow cranially into the middle fossa. Those are quite frequently very complex tumors, like this one, which is orbitosphenopetroclival tumor, which is almost impossible to treat surgically. What about the cavernous sinus? There are typical triangular tumors if only the cavernous sinus is involved, and I do not think that these tumors are surgical disease. We treat them either by observation or by radiosurgical means, but they are variable because the tumor grows outside the cavernous sinus and various compartments may be involved. We then do that only the extra cavernous part is resected if necessary, and sometimes we go for optic nerve and chiasm decompression with chiasmoplexy with fat to move the optic apparatus away from the tumor to allow for radiosurgical treatment to be able to deliver the sufficient dose. You see such a complex tumor in the middle fossa, which we resected, but only from outside the cavernous sinus. The piece of the tumor in the cavernous sinus was left behind. Very rare tumor of Cavo Mekeli, again with some extra tumoral growth. The temporal edge tumors, they are specific that they are posterior to the vessels, not only the large vessels, but posterior, and they stretch the perforators from M1 area. That is their danger and difficulty, but they can be dissected. We then have posterior glinoid tumors, which are, in my mind, the most difficult ones because they literally are posterior to the Lilienquist membrane, making them virtually posterior fossa tumors. But they are usually approached the arteriole from above. This one was rather easy one. The same approach during the glinoid process, then dealing with the tumor along the tentorial edge to get as far back as the fourth nerve entry. Then you can cut the tentorium and get some more space, which was not necessary in this case. So the third and fourth nerve are very endangered. Then the tumor is released and resected. That was the only vessel which was adherent, that small hypocampal vein, and you see the superior cerebral and posterior cerebral artery. We didn't need to cut the tentorium in this case because the tumor was nicely delivered, so it probably was not really true posterior glinoid tumor. Here is the true posterior glinoid. You see, compared to anterior glinoid, the posterior glinoid is posterior to the vessels, stretching the third nerve and stretching all the perforators and major arteries with the origin at the glinoid area. And these are really the extremely difficult tumors. Middle fossa proper, various tumors, some of them very easy, or let's say majority of them rather easily approachable. The upper pyramid surface, you see that you do not need to remove that much. You go subtemporally with minimal retraction. You see the whole tumor, and it really is easily resected. And this is the tumor in a young lady who already had some communication problems, so we didn't want to move any part of her dominant hemisphere. Thus, the approach was from below, supracerebral infratentorial. Here we are in front of the tumor, cutting the tentorium down to the superior petrosal sinus, and then it goes along the tumor from anterior to posterior again, back to the petrosal sinus. We do not need to care about the collateral flow because it goes anteriorly, so there is no problem in that. And after the tumor is decompressed and removed like any other meningioma, you see the tumor cavity perfectly clean. This is the cerebellum. No retractors are needed in this case, and this is after surgery. And you see that whole dominant hemisphere is unharmed, and the lady is doing perfectly well, being treated by this simple approach. Variable tumors are middle fossa, and there are many of them. Individual approach, perional with temporal extension, is probably the most suitable one. Lumbar drains more or less like 30 cc because you do not reach the cisterns immediately, especially via subtemporal approach, and you do not want to move the temporal lobe, especially if it's a dominant side, so drain more. And lumbar drain in my hands, it's almost in all the cases. I believe that lumbar drainage is the best invention in neurosurgery. Endangered third and fourth nerve in medially located tumors. Partial resections in true middle fossa are seldom. And what's important, and it's a general rule, sue the approach to the lesion, not vice versa. If you like petrosectomies, don't use it for all tumors. especially not to those tumors which can easily be resected by some simple approach. And choose the approach which is most familiar to you. It's always very important if the approach is familiar. We've published this supra-infra approach. It's variability and possibility. Actually, I treat all the petroclival meningiomas via supracerebral infratentorial route. This was published with friends in Lausanne, and that was a really nice collection of various cases. Rectus pineal tumors, very variable, but in general there are two types. The type number 1 are the tumors of the sinus rectus. Type number 2 are the meningiomas which grow within the pineal system, true pineal tumors like this one. This would be the rectus tumor, again the rectus tumor, again the true pineal. They are not as infrequent as we believed. There are quite a lot of them. This is such a typical tumor in the location. You need to know about the veins. You need to know about the post-transverse sinuses to choose the site of the approach. And that doesn't matter much whether you come from infra or supra tentorial route. I'm doing all of them via infratentorial, but if I need to, I open the dura supratentorially as well. You see that the rectus sinus, which is always the most important question in this tumor, is occluded. Thus, you may perform simply one resection. See here, this was not the overlooked piece. This is the piece of the tumor left intentionally there. It serves as a plug in the rectus sinus, because if you would open it away from you in a way, you would be in a bad position, because close to the torcular you might be unable to control the bleeding. Actually, the remnant is stable for several years by now. This is a true pineal tumor with no relation to the dura whatsoever, and it's growing in one of the systems which is easily forgotten. It's velum interpositum. This part of the tumor is within the velum interpositum. So actually the tumor grows in pineal system. It pushes the ambient systems laterally and downwards, and it grows anteriorly to the velum interpositum. This was the last bilateral supra-infra approach I did, probably one in the past 15 years, but the tumor was really very extensive and I wanted to have my hands free. So this is the tumor being approached. This is the arachnoid of the pineal system, which is being cut because you cannot lift it. You have no way to preserve it, so you have to go through. And first is the lobule, which is on the left side. The tentorium is cut as far as to see the temporal lobe, which is just over here. And here is the tumor. Little trick to get some more retraction is to put one extra stitch on the tentorium and lift it out of the wound. It gives you another 2 or 3 millimeters, which may be very valuable. Here we are resecting the lobule being supratemporally, and as it is resected, you see the corpus callosum. Of course, it will help in all cases. Forward, this is the corpus callosum, and you move the tumor medially, releasing the corpus callosum, and now we shall get to the part of the tumor which is pointing anteriorly into the velum interpositum. That's it here. You see the lobule, and you see the arachnoid with all the vessels. This is the Rosenthal vein on the, no, this is the internal cerebral vein. The Rosenthal vein is here, the other opposite Rosenthal vein is over here. And this is the piece of the tumor which is in the velum interpositum. We thus are entering the third ventricle, releasing all the tumor from its bed, which is composed by the velum interpositum arachnoid. The vessels were quite difficult to dissect free because they were actually held in a very long stretch. And here we are nearly at the end. We still have piece of the tumor on the left side, but here you see the opening into the third ventricle. You see the vessels, you see the opposite side Rosenthal vein, which is preserved. Let's go a little forward, the internal cerebral veins. And here we are looking on the choroid plexus of the third ventricle. This is after surgery, and you see the velum interpositum is free of any tumor. So go now to the convexity, and I shall restrict only to the eloquent tumors, only to the veins, and only to the sinuses, which I shall discuss very briefly, because otherwise it would be too much. As to the eloquency of the brain, many years ago we published this article that the monitoring and direct stimulation is very helpful and very important. And all of this depends on the type of growth. As Yashargil has said, non-adherent, which is this area, adherent, which is this area, harming the arachnoid, but not harming the cortex, and then adhesive, which is this part, very small one, but still exists, where you definitely will harm the cortex. This is actually the history of the recent classification of the tumor, where the type of growth is the important factor. What it means technically, the central or Rolandic tumors, or in any other eloquent brain, if the tumor starts growing anteriorly to the motor strip, then again the sulci are moved and the arachnoid again is moved along that. So in this case, the motor strip is very well covered by the arachnoid. You will end up with a web of arachnoid, but still the motor strip will be posterior to that. And these are the troublesome tumors which grow directly from above the motor strip. And then again, the motor strip is covered by the single arachnoid layer, which is easily penetrated even by small tumors. So these are the difficult and dangerous tumors. You see what it looks like. This is like a tumor in the motor area. You got your functional, you got your tectography. Then during surgery, what's important is the monitoring and stimulation. And you see that at the end, this is the motor area, and still the responses are perfect, and you knew that you did a good job. So perioperative monitoring in these tumors is important. Going to the veins. Now you hear all the lectures and all the publication. Preserve all the veins. Don't interrupt a single vein. That may be dangerous. Okay, we have all seen venous infarctions and we all know about the importance of the veins. But it's not as easy as that. You see, I definitely would preserve these veins which are anterior to the tumor. That would be my task. But what about this big one? Posterior to the tumor. The large vein, which is perfectly connected to Sylvian Fisher system and perfectly connected to vein of Labbe system. I wouldn't hesitate to sacrifice this vein should the need be. It's nothing that would bring any problem. I would be hesitating here. What about the sinuses? Check them prior to surgery, especially those in the posterior third of the superior sagittal sinus, in the middle third. There are many articles and many lectures about the repair of the sinuses, but it's still I have some hesitancy about that because I didn't see too many post-op angios or post-op results with preserved sinus. And to keep the flow, the cerebral vascular surgeons will understand that it's not easy in a structure which is firm and which has the pressure of 0, even negative if the patient is standing. So I really hesitate about that, and I do not repair the sinus. I better do not enter the sinus. Leave a piece behind. You have radiosurgery and you have means of control of the tumor. If possible, wait for the sinus to But even if the sinus is occluded, check the veins which enter the sinus which is occluded. They may be important and they may be working, not seen on any MR or angio if you do angios. In this case, there's a junction, sinus junction tumor, and you would think that here the radical resection will be easy because the dominant, actually the only sinus, transverse sinus in the opposite side. Actually, that was not true because in this not seen sinus, the vein of Labbe entered. And we were pushed to leave the piece of the tumor behind because of this vein of Labbe orifice into this area of the junction of the transverse and sigmoid. The opposite case, again the tumor in the same location, and again the transverse sinus developed only on the side of the tumor. You would expect to leave a piece behind in this case, not to harm the only sinus the patient has. Not true. Easy resection with complete, with Simpson 1. Let's go to general remarks. And, as I understand, this is the teaching lecture. So let me generally put forward that the basics of all is knowledge. You must learn the craft. It is the same mechanism as Dali had to draw. He was very good at drawings. See his drawings. This is the craft. This is what you really must know. And this is something which can be learned at medical school, after the medical school, wherever, at home. There are books and everything. Then you go into trade, your profession and dexterity, and you get it by practice. By practice, you did these beautiful paintings, like Dali did. There is already some creativity, some imagination, but it is perfectly normal anatomy. So this is really the profession which is performed on a top level. And then the next step is the idea, creativity, something forward. And that is the distorted anatomy by the tumor. You must expect the structure to be somewhere. You must be aware that over there, somewhere, could be the third nerve, whatever. And that's probably the last step in the education. Also, we are not anymore more fighter pilots as we used to be in the 90s, when only surgery was available. In the past 20 years, we have radiosurgery, we have interventional neuroradiology, we have much potent medical treatment, we have the combination of all the above. And suddenly the legitimate policy appeared and is wait and see. I wouldn't operate on a small tumor which is asymptomatic on the first side. I would check the tumor in half a year or a year, and only if it will grow, I will start thinking about surgery. And only if it will become symptomatic, I will start thinking about surgery. There are many, many meningiomas which do not need any surgery at all. And that is the mentality of the airline pilot, which we are now. Something's wrong, get down to the nearest field. Not anymore filling the mission at all costs with any collateral damage. So the mentality over the past 20 years, in the 90s, which were the top of surgical endeavor because there was nothing else, is well past, and we really need to be safe. See this patient. There are 4 years between these two images. The lady is 47 when she came to me with this meningioma and with some visual deficit. She was given some female hormones by her gynecologist to look better, to feel younger. And the tumor grew. And just by taking away this medication, and in 4 years' time, the patient is still asymptomatic, and the tumor is small by 1/3 or nearly half volume, right? So this is about the observation and about the surgery which can be postponed. Simpson 1 in meningioma frequently means really cure. So that's what we are aiming at. However, the aim of meningioma treatment is not to resect the tumor entirely. It is to ensure the patient high quality life, it means normal life in all respects, of its given length. It's the same like with pituitary adenomas. You want to give your patient the normal life in its given length. You do not need to really cure the meningioma. So do not strain Simpson 1 resection for neurological deficit. That's probably the most important message I would like to give you. And just recently, as we are talking about the veins which cannot be sacrificed, we are seeing too many lectures in my mind where there is no mortality in meningioma series and very low morbidity. This is not true. There is mortality and there is morbidity in meningioma surgery. You cannot expect you will have 0 mortality and 1% morbidity. At least there are these too much too late cases. You get a patient who is 90 years old, who's got growing meningioma, a large one on the convexity. The patient has 2 cardiac bypasses, he's got diabetes, and you know that you will harm him. But since the tumor is growing and the patient is more and more hemiparetic, you cannot decline surgery. Those are exactly the cases where you will expect some morbidity, mortality. But not only, this patient is 45 years old lady. Rather not difficult, I would say tumor, very straightforward surgery. The patient was doing perfectly well for 3 days, and this is the day 4 after surgery. The opposite side, thalamic bleeding, and the patient died. So there is mortality. This is the patient that I was too much too late case. See, his tumor is growing, it's causing hemiparesis, which is developing, but the patient is 87 with many medical diseases. What we did, we took him to OR in the intra-op MR setting, and we intentionally left quite a lot of the tumor behind. And to our nice surprise, the patient lived for another 4 years. What about the remnants? They are not shame. In this petroclival area, there is sometimes not really a good plane of dissection between the brainstem and the tumor. So these 2 pieces were left behind. This one is stable and only under observation. This one progressed and the growth was arrested by radiosurgical means. So the remnant is not a shame. The remnant is sometimes in a good position for the patient. I would recommend you for reading these 3 articles we've put together with EANS skull-based section and few friends from around the world, like Al-Mefti, Ohata, and others. There are petroclival meningiomas, all the data known, the glinoid meningiomas, consensus statement, what should be done, and tuberculum cellae meningioma. Those are really 2 very nice articles where you get all the information at one article. We've published Simpson 4 meningioma resection if it would improve its adjuvant radiosurgery. Yes, it would. Then we've published this article on supra-infra approach. Then spinal meningiomas. That was another topic. If Simpson 2 is enough, it's not for young patients. In young patients, you should resect the dura. And just for the fun of it, we've published the meningiomas in dogs. I did some 25 dogs. We have better results than the veterinary medicine because we know how to remove meningioma, unlike them. And you see here the tumor in a dog. Here you see the lateral brainstem, and this is the patient view out after surgery. To conclude, and let me make it very, very simple. Arachnoid is a friend. It helps you, and it's your best accompanying structure throughout the meningioma surgery. And arachnoid belongs to the patient. So leave the arachnoid behind. That's probably the only message I could give you. It's on behalf of the WFNS Neuroanatomy Committee, which we are not anymore, but we did many webcasts with John. We did now convert to International Academy of Neurosurgical Anatomy, under which auspices, although this lecture was given, and I believe we are doing good job since we visited many places with our courses. Especially, we believe that it's valuable in Africa. This is my city. It's a capital of Czech Republic. It's Prague, which is probably the most, not probably, but surely the most beautiful place in the world. And this is my university, which was founded in 1748, making it the oldest university outside Italy. And this is the Charles IV, the important king who started my university. Okay, that's it. And I'm sorry for the slides if they didn't work properly, but I hope that everything worked, at least on a little small version. Thank you very much for your attention.
Thank you,
Thank
Vlad,
you,
and-
Professor Bennett. Yeah. Thank
ahead,
you for
go
your
ahead,
very
Ben.
nice presentation, and your concept is very important, and we learned a lot from your presentation. Thank you again. And
Thank you very
you don't
much.
need,
And, my
you don't need to
apologies.
say sorry, because that's just a technical issues.
Yeah, I'm sorry for the inconvenience with my presentation. It happened several times. John, think about it and let me know, please.
I'm glad you were persistent and you got it going. Thank you for keep trying.
Thank you. Thanks for invitation. That was a great pleasure and honor for me. I forgotten at the beginning to thank, but I'm really very, very honored to be invited to these seminars.
Oh, great. Okay, Ahmad, do you have a question or comment from Afghanistan? Go ahead.
Okay, thank you very much. I was busy in another ACNS YNS webinar, and I also follow some topics in this webinar. Thank you very much, and inshallah, as soon as possible, we will have our Afghanistan Neurosurgery ground now, and we also like to say thanks for Professor Benju for supporting Afghanistan neurosurgery. Thank you, Professor
You're
John.
welcome.
Thank you.
Thank you, Professor.
Thank you.
Go ahead, Mazin, you have a question or comment?
No, thanks.
Okay, I think someone else, Mazin, did you have something to say? I wasn't sure. Oh, I guess no, not coming through.
Mali,
Hi, Professor Xu.
hi.
Nice to see
Go ahead,
you.
Lee.
Do you have some comment?
Maybe a very brief question. And thanks, Professor Lamir, and it's a very great presentation. It's much great appreciated. So I have a question. When you're dealing with a kind of a meningioma which is engraved, the ICA, is there any tricks when you do the debulking to identify the vessels when you do your surgery? And thanks for that.
Yeah, that's probably the most important question for glinoid meningiomas. I have not found any. You know, I just know where the carotid will be. I have in my hands the distal ring, which leads me to the vessel directly. I have distal carotid, always, not a problem to dissect it. But then there is no way to recognize whether the tumor will be very adherent or growing into the wall of the carotid artery, especially if the carotid artery on pre-op images is narrowed. Then you can be sure that you will not be able to dissect it free, that the tumor is within the carotid cave and that the wall will be affected. That's the only mark prior to surgery which gives you some information. Otherwise, in all these tumors, I expect the worst. It's always better. I expect that the wall will be affected. And you saw the case that there really was no recognizable plane of dissection between the tumor and the vessel wall. So narrowed artery and carotid cave location are the two risk factors for this occurrence. And this is something you must be aware of prior to surgery. And in this case, I do not remove the tip of the glinoid extradurally. I wait for intradural part of surgery. So this is the important question, because glinoidal meningiomas are frequent. Glinoidal meningiomas are very benign, and you may harm the patient very easily, because if you deteriorate the vision, that happens. That usually improves. To make the patient blind, it's very, very seldom, but all of this happens. But to damage the carotid artery means a stroke, which is a very serious complication, but no way in advance. Just some hints. Someone asked if the artery goes through the tumor, how you save the artery? I leave the piece of the tumor behind. I always leave the piece of the tumor behind. That's my question, and someone probably would be able to answer it, whether to start with radiosurgery up front or whether you would wait for progression. We wait.
Very good.
We follow.
I'd like to say hello to Juha. Juha, would you like to make a comment or say hello to your friend Vlad?
Juha is with us?
Yes.
Hello, hello, Vlad.
Hello, Juha.
Hello, Professor.
Hi. How are you doing, Juha? Good to see you.
Perfect lecture, so there's
Thank you.
not much to add. So as you said, that when you are doing meningioma surgery, you have mortality and morbidity. I have done more than 1,300 meningiomas and analyzed some of them very well. Professor Rosanna Romani, working now in London, England, she analyzed more than 10 years ago all anterior fossa meningiomas, olfactory meningiomas, suprasellular meningiomas, and anterior glinoid meningiomas. I operate all through lateral supraorbital approach. So there was no mortality or very little morbidity in olfactory meningiomas. In suprasellular meningiomas, we lost one case several months after surgery in pulmonary embolism. We count in mortality all cases within 1 year after surgery. And then in anterior glinoid meningiomas, I had in two cases. I had a lesion in carotid, and the patients died later crippled. So in around 200 patients, we lost 3 cases, one pulmonary embolism and one stroke. So this is how it is. But otherwise, we were doing well. And this is a very nice PhD done by Professor Rosanna Romani from Italy. Now she's in London, England. If you want to take a look, it is very good analysis. And as you know, in Finland, you have the possibility for long-term follow-up. So there's an extremely long-term follow-up for every case. But it was excellent lecture. Thank you. Everything was covered, and it is difficult to do better than in this series. So thank you very much.
Thank you, Juha. Thank you, Juha. But even you prove that there is mortality and morbidity. You cannot be doing meningiomas with 0 mortality and 0 morbidity. There are patients. Yeah,
this is nonsense. This is nonsense. Yeah. If you go around and tell that you have no difficulties, no mortality, no morbidity, then you have no follow-up of the cases. Exactly. You have no follow-up of cases. You lose the patients go around. You are coming from big countries, you have no follow-up, careful follow-up. So in Czech Republic, you have a good follow-up. In Finland, you have good follow-up. Yeah. You know every case. So then, then you have to, like Dr. Drake, my teacher said, You have to be honest. And when you are honest,
That's
it
it.
hurts. And it hurts,
That's
really
it.
hurts.
That's it.
But this is
Even
very
at
important.
even at your age, you are very optimistic, saying that those are the lost patients. I'm afraid that they are lost intentionally, some of them. You must really be honest. That's important. Thank you for the remark. I fully agree with you.
Yeah. It was great lecture, so everything was covered.
Thank you.
So thank you very
Thank you
much.
very much. Thank you, Juha.
Thank you. Bye-bye.
Bye-bye,
Hi,
Juha.
Professor Juha. Nice to see you again.
Yeah.
Long time not seen.
Yeah, how
I
are you?
was blocked here in Helsinki.
Okay.
I left China
Thank you.
end of November,
you.
but then there was a
Bye-bye. Thank you.
lockdown in Shanghai and then came the Ukrainian war. So now I'm here. I should have begun my working in China again April 1, but now I'm blocked here. But what I'm doing, I finished my memories, so they will come now next month out and next year in English and other languages. So
Looking
Okay, that's
forward
great.
to that. Looking
It-
forward to the book.
yeah, this was in China. You were so isolated and little possibilities to travel, so you had to do something. So I wrote my memories.
Good.
Okay, Ben?
Thank you.
Okay, so now let's move on to the second speaker.
Kitang, correct?
Thank you, Manis.
Thank you.
I think Professor Zhao Yuanli is here. Yeah.
Dr. Kitang, correct?
玛丽，
哎，
这个汤可教授他没来吗？
来了，我正在等着呢，
哦，
还没加进来呢。
还没加
I'm
进
waiting
来，
对，
那让他赶快进来啊！在哪里啊？在
我已经上线了。
哦，
他要邀请我才能共享屏幕，我这时候都只能是
你是在
那个。
哪里？哪个？
我在单位，是我已经上线了，但是他没有邀请
哦
我进来。
，ZY，OK，
对
John，
对
Yes.
please let ZY into the panelist. Then he can
Oh, okay,
yeah,
okay. So
share
he's
his
not-
screen.
Okay, there, I'm sorry, yeah.
Yeah.
We'll get him in here. That was a problem. Okay, he's coming in now.
Yeah.
That should solve it. Dr. Tang, you okay? There you go. Okay, you're all set.
Okay.
Thank you very much. We can start.
Yes.
Okay. Dear professors, members, thank you very much. It's my pleasure to introduce some of my works. My report was multimodal imaging in neurovascular protection of gum-knife radiosurgery. As we know, the neurovascular anatomy is a key point to decrease injury risk intraoperatively. Cadaveric dissection is a traditional approach to acquire information about neurovascular protection. However, the cadaveric dissection is a hard work, not convenient, and cannot provide individualized guidance. So we try to establish three-dimensional anatomic model. On the cadaveric head of anatomic laboratory, reconstructed images of osseous bony structures were extracted directly from the CT data, obtained prior to the artery and vein perfusion on the cadaveric head. Reconstructed images of the brain tissues were also extracted directly from the MRI data, obtained prior to the cadaveric dissection. Reconstructed images of the artery can be obtained from the CT data obtained after the artery's perfusion. Reconstructed images of the veins can be obtained from the CT data obtained after vein perfusion. Then the three-dimensional images of the cranial nerves were extracted from the MRI data obtained after the cadaveric dissection. Each structures can be distinguished by coloring to establish a model. We can see the observed results of the three-dimensional model from the multimodal imaging were consistent with those of cadaveric head, and the three-dimensional anatomic model can be used to make surgical planning. We also use multimodal imaging to conduct lesion-specific modeling for the path planning microsurgery. Briefly, we also use the data of MRI and CT to establish model. The MRI protocols include the T1 weighted sequence, contrast enhanced T1 weighted sequence, T2 space sequence, and time of flight TOF sequence. In addition, we performed rigid registration to align all the images and outline the contours of the lesion, osseous, and the neurovascular structures. How to use imaging for the anatomic analysis? When we meet the question, for example, the appearance of AVM after complete resection of ruptured AVM, true recurrence or false negative early post-operative imaging results. Let's discuss this case. The DSA showed that the AVM feeding artery included the posterior parietal artery and angular artery arising from the middle cerebral artery, supplying the nidus laterally, and the parietal occipital artery arising from posterior communicating artery on the carotid angiography imaging, supplying the nidus medially. The drainage vein included the vein of Trollat, connecting to the nidus laterally and superiorly and draining into the superior sagittal sinus. The vein of Levy, connecting to the nidus laterally and inferiorly and draining into the transverse sinus. And the middle temporal basal vein, connecting to the nidus medially and inferiorly, and also draining into the transverse sinus. The area involved by the AVM might have included the angular gyrus and the superior occipital gyrus laterally, and the cuneus and precuneus medially. Based on the above anatomic analysis, we postulate that the appearance of the AVM might be due to a remnant that was left after the surgical procedure. A parietal craniotomy might have been performed, and the resection might have begun with the lateral part of the nidus, following the occlusion of the parietal artery and the angular artery. The dissection of the major nidus would then be achieved. In this scenario, the vein of Trollat and the vein of Levy connecting to the nidus laterally could have been separated successfully, but the medial fragment of the nidus might have been remained hidden due to the deeper location in the precuneus. Vasospasm of small edema might then have masked this remnant on the early angiographic images. Postoperative. As the illustration shows, the recurrent AVM was located in the inferior portion of the precuneus and was supplied by the parietal occipital artery and drained by the middle temporal basal vein, which would both be located in the deeper surgical field. We believe that the microsurgical anatomy plays a dominant role in AVM recurrence. Preoperative and intraoperative anatomic analysis is essential for the complete resection of AVM and prevention of recurrence. Anatomic identification on the imaging is another key point for this case. We want to talk about this DTI force, the run, from the views of neural anatomy. According to the rule of neural connections, the nerve fibers consist of axons from the neurons. Thus, the fibers of cranial 3 arising from the oculomotor nucleus and the VE nucleus to connect the intraocular and extraocular muscles, whereas the fibers of the medial longitudinal fasciculars mainly arise from the vestibular nucleus to connect the oculomotor nucleus, trochlear nucleus, abducens nucleus, accessory nucleus, and anterior horn neurons of the cervical cord. Mutual connections between the above nucleus in the brainstem and spinal cord also exist in the medial longitudinal fasciculars. Synergic movement of the ocular and neck muscles is controlled by the above connection of the medial longitudinal fasciculars. Direct connections between the medial longitudinal fasciculars and the ocular muscle do not exist. Obviously, it is also a false continuation of the fibers of cranial nerve 3 arising from the medial longitudinal fasciculars directly. Axon cannot arising from axon directly. Limitations and potential artifacts associated with the DTI technique can provide false and misleading information. Thus, careful anatomic analysis is therefore essential to avoid the false of imaging. Then, we use multimodal imaging to make anatomic analysis for the plan of gum-knife radiosurgery. Diagnostic MRI co-registered with stereotactic CT can be used for accurate target location. When we use stereotactic CT, the mean error of the fiducial position is 0.1 millimeter. The maximum error of the fiducial position is 0.2 millimeter. CT scans can avoid geometric distortion and provide accurate stereotactic space by precisely defining the fiducial localizers. Multimodality MRI images can help to identify the neurovascular structures. A satisfactory imaging fusion can be done if the cranial nerves showed in the MRI fit smoothly into the skull fragments shown in the CT. So precise targeted localization can be realized by a combination of accurate stereotactic space in CT and clear anatomic identification in MRI. The application of multimodality imaging co-registration to stereotaxis avoids the problem of additional intraoperative MRI and reducing the time of stereotactic head frame immobilization. It can be used to achieve satisfied neurovascular protection of gum-knife radiosurgery. The case 1, females, 13 years old. We can see cerebral hemorrhage on the CT. The DSA show AVM at 10 days following hemorrhage. The nidus located in the cerebellar vermin. The supplying artery is posterior inferior cerebellar artery, and the drainage vein is suboccipital sinus. Gum-knife was performed at 1 month following hemorrhage. We use 320 detector raw dynamic volume CT angiography to discriminate nidus, supplying artery, and drainage vein. There are different stages of dynamic volume CT angiography. There were MRI imaging to show the clot. Since we discriminate the supplying artery and drainage vein, we seek more radiation dust on the supplying artery and make dust constraint on the drainage vein to make protection. The post-gum-knife MRI and DSA showed disappearance of the nidus at 1 year following gum knife radiosurgery. Satisfied neurovascular protection was also achieved. We can see the normal gait of the case. For brain AVM, we use multimodal imaging to discriminate nidus and the surrounding neurovascular structures, and good outcome was achieved. The case 2, female, 54 years old. She had numbness in right face. MR scan showed a lesion of cavernous sinus. She underwent craniotomy, but only biopsy was done for the cardiac arrest in the operation. The pathology reports showed meningioma, WHO1. The volume stage of gum knife radiosurgery was designed. Stage 1. Prescribed dose was 14 gray, 30% isodazolone. The dose focused on the posterior part of the lesion. We used the multimodal imaging to show the neurovascular structures surrounding the lesion. We can see the cranial nerves 3 to 5 distortion and make dose protection for the cranial nerves. To achieve tumor bed effect, we also set high dose on the Bernasconi casinary artery, the supplying artery of the posterior wall of the cavernous sinus. Volume stage 2. Prescribed dose was 14 gray, 30% isodazolone. The dose focused on the anterior part of the lesion. We also make dose protection for the cranial nerves. To achieve tumor bed effect, we set high dose on the inferior lateral trunk of the internal carotid artery, the supplying artery of the lateral wall of the cavernous sinus. The post-gum knife surgery MRI of last follow-up showed tumor control at 4 years following gum knife surgery. We achieved sensory recovery in the right face at 1 year following gum knife surgery. And the conservation of normal function of cranial nerves was also achieved at last follow-up. We can see the normal oculomotor function. The case 3, female, 26 years old. She had hearing loss in the right ear and was diagnosed with neurofibromatosis. MRI showed bilateral vestibular schwannomas, right trigeminal schwannoma. Meningioma in the left frontal lobe, box right occipital lobe. The hearing of the left ear was normal. The hearing of the right ear reduced to 16%. The gum knife surgery was performed. Schwannomas with prescribed dose 12 gray, 30% isodazolone. Meningioma with prescribed dose 12 gray, 50% isodaz for the false right occipital lobe lesions, and 12 gray, 55% isodaz for the left frontal lobe lesion. We reconstructed facial nerve, acoustic nerve, superior vestibular nerve, and inferior vestibular nerve, and made dose protection. The maximum dose of the acoustic nerve was less than 8 gray for both sides. All lesions were controlled at 3 years following gum knife surgery. All the schwannomas were controlled at 5 years following gum knife. At 5 years following gum knife surgery. At the last follow-up, a new lesion in the jugular foramen was found, and the meningioma in the left frontal lobe relapsed. The radiation dose of this meningioma was insufficient. It might be a lesson that the prescribed dose isodazolone was 55 for this lesion, so it is insufficient. Fortunately, the other lesions were well controlled today. The hearing of the left ear kept normal. The test score of hearing of the right ear was somewhat increased. We could see the successful conservation of hearing for the bilateral vestibular schwannomas. Using multimodal imaging, we performed the visualization of the neurovascular structures surrounding the lesion. The imaging of T1 weighted sequence and T2 space sequence showed the cisternal segments of cranial nerves. The tall sequence showed artery. The high signal of contrast enhanced T1 weighted sequence was used to show the vein, and the cardiac segment of cranial nerves was shown as lower signal on the background of high signal of vein. We can see the three-dimensional anatomy of skull-based neurovascular structures. For pituitary adenomas, meningioma, and schwannoma, we can see the tumor control. The neurovascular protection was satisfied. Okay. The case 4, male, 54 years old. She has paralysis in the left ear, left side. MRI showed a mass lesion in the brainstem. The patient refused surgery. MRI suggested brainstem glioma. The dust fractions of gum-knife surgery were performed. Fraction 1. Prescribed dust was 12 gray, 40% isodustlan. DTI tractography showed ventrospinal cerebral tract, medial lemniscus, and dentate thalamic tract. This was the dust distribution in the lesion. We performed dust protection for the conduction tract. Fraction 2. Prescribed dust, 12 gray, 40% isodustlan. This was done protection of the conduction tract. The post-gum knife MR shows the tumor shrink, and working recovery was achieved. But a new lesion in the medulla was found, and we performed gum knife surgery again for the new lesion. Prescribed dust for this lesion was 12 gray, 40% isodustlan. DTI tractography showed inferior cerebellar peduncle and cortical spinal tract. We also make dust protection. We recommend whole brain radiotherapy and adjuvant temozolomide treatment. Unfortunately, the patient gave up further treatment. The follow-up MRI showed shrink of treated lesion. The working function was still normal. We also made dust protection. But other new lesions widely disseminated. We recommend again the whole brain radiotherapy and adjuvant temozolomide treatment. The patient gave up the recommendation again and only received corticosteroids. He died at 20 months following gum knife surgery. The lesson is that the pathological examination and the multidisciplinary teamwork cannot be ignored for this case. The case 5, male, 61 years old. He was diagnosed as brain metastasis of esophageal cancer and had hemiparalysis in the right side. MRI showed brain metastasis. The patient underwent craniotomy. Resection of the left parietal lobe lesion was achieved. Pathological results were squamous cell carcinoma. Temporary recovery of working function was achieved, but he had hemiparalysis again in the left side for the reason of the progression of the right frontal lobe large lesion. The dust fractions of gum knife radiosurgery were performed. Fraction 1 for the right frontal lobe lesion. Prescribed dust was 10 gray, 20% isodustland. DTI tractography showed bilateral superior longitudinal fasciculars. Pyramidal tract. This was the dust distribution in the lesion. The remaining lesions, 70 gray, 50% isodustland, and 50 gray, 60% isodustland. We performed dust protection for the conduction tract. Fraction 2. For the right frontal lobe lesion, prescribed dust, 10 gray, 20% isodustland. This was dust protection for the conduction tract. The post-gum knife radiosurgery MRI showed tumor shrink and working recovery was achieved.
The video's frozen, looks like.
Fiber tractography, another imaging model, can be used to show the conduction tract adjacent to the lesion. You can see the tumor control and the neural function was protected. In summary, multimodal imaging with imaging fusion can be used to show anatomy of neurovascular structures and set sufficient dust to the treated lesion and make dust protection for the neural function. The protection of neurovascular structures depends on the pair of neurovascular tolerated radiation dust and lesion effective control radiation dust. On the base of visualization of neurovascular structures, it will be interesting to compare the traditional physical dust parameters and three-dimensional biological effective dust parameters in future studies. Thank you very much for your attention. Thank you.
Okay, Dr. Z, thank you very much. Ben, are you there?
Yes.
So hold on a second. Okay, I'll get you off the screen, okay? Well, before Dr. Ben comes on, I'd like to invite you to present. We have a new channel, Gamma Knife TV, which, let me see if I can get it up here. Here it is. Can you see that okay?
Yes, it's a good opportunity to study.
Yeah, it's a new channel. We are having people present from different countries. This is from India. We're trying to get what it looks like in different parts of the world, the Gamma Knife. And we invite you to present.
Thank you.
And just please leave your email address in the chat, and I'll get in contact with you and love to have you present and say this is what's going on in China and Gamma Knife, and they'd be able to compare what's going on in India. I mean, I think it's a win situation. So
it's a good opportunity, the communication. Thank you.
Okay, we welcome you. Okay, any comments or questions from the panelists? Hello, Takashi, are you there?
Thank you. Thank you for great lecture. So I'm so impressed about your images and imaging treatments. So today I'm working in a night shift, and sometimes I have to go to the ER, so I cannot listen completely. So I'm very sorry, but we keep attending this seminar and learn. Thank you so much.
Thanks, Takashi. You'll see him at Gamma Knife TV.
If I have time. So now I'm free, and on the work, still working, but I'm free. So I will attend the Gamma FTB. Okay.
Okay, thanks, Takashi. Any more comments, Ben? Go ahead. Ben.
Thank you, Professor Tonko. Very nice presentation. And actually, I'm surprised. The picture is so beautiful, so colorful. And you mentioned that you have you sent some letter to the editors that you mentioned some false by the fiber image. So why there's some false leading for this technique? Yeah,
because the DTI technique has its limitations. He used to calculate the direction of the water movement, but if the fiber change its direction, it will the wrong calculation will occur. So we can see the false connection of the fiber.
Okay, so this is according to the calculation, but not the real examination.
Yes.
Okay. Thank you.
So we must use our anatomical information to study the wrong.
Okay. Now I understand. Thank you.
Thank you.
Very good. Any more comments or questions from the audience? Let's see here. Dr. Helmy, are you there? Okay. And let's see who else we have here that I can pick on. Okay, well, I guess if there's no more comments or questions, I'd like to thank Keaton for a great presentation. I'd like to thank Vlad, the old veteran, and I'd like to thank Yuha for coming and the other panelists for coming, and of course, Ben for putting this all together. And we look forward to our presentation in a couple of weeks, number 10 for the China Neurosurgical Journal webcast. And so,
okay, John.
Yes,
Yuan Li is in the audience list. You can invite him.
I'm sorry, who's here?
Yuan Li, Zhao Yuan Li.
Oh, he's here. Okay, okay.
Yeah.
Wan Li, you here?
Yes, in the audience list.
Oh, okay, maybe I haven't let him in. Let me check here. Oh yeah, here he is. Okay, sorry, I prematurely ended there. Yeah, I think I'm going to ask Wan Li and Yi to give a couple cerebral vascular webcasts. Are you there, Wan Li? Did you come in yet? Still not in. Okay, he'll get in here. Hold on. We'll get him. Sometimes the internet's not so good and they have a hard time getting in. Unfortunately, Ben, looks like we can't get him in here. So go ahead, Wan Li, are you there? Can you hear me? Things aren't going our way today, Ben.
Okay, so let's finish today's webinar.
Yeah, thanks everybody for coming, and thanks Ben for putting everything together. And we'll see you in 2 weeks.
Yeah.
Okay, thank you.
Today we have around 800 audience.
2 weeks. Yeah.
And from China, that's excellent.
Yes,
Great.
yes.
Okay, see you in 2 weeks.
Okay, see you.
Okay, Keith,
Thank you.
Dr. Yeah, thanks. Thanks, Ben. Yuha came. That was a surprise.
Yeah. 好，谢谢汤可，谢谢玛丽。
Thank you.
好，拜拜。
Dr. Tang, are you there?
Yeah.
Yeah. I'll invite you.
Excellent conferences. Thank you.
Thanks, Jorge, for coming. Let's see, did you put your name, did you put your emails in the panel, in the chat, Keaton? Do you know what the panel is, right? In the chat.
Thank you.
Put your email in the chat, okay?
Thank you. Okay, I will try.
Okay, very good. And you'll be hearing from me, Lee, about maybe we can get a couple of cerebral vascular webcasts, you and Juan Lee, maybe. But I'll
Okay.
be in contact with you.
Thank you.
And
Okay,
of course,
thank you.
anything you want, Ben, anything besides this, is let me know.
Okay.
Okay, Bayam Batson's here from Mongolia. Hi, Bayam Batson. You want to say hello to people? Well, reaches the far reaches of the world, Afghanistan and Mongolia.
Yeah.
Bayam Batson comes in here. I guess there's 50 neurosurgeons in Mongolia.
15 or 50.
50.
Okay, okay, 50.
Yeah. Mohammed Helmi, you know him. Juan Lee's just not getting in here.
Okay.
Oh, very
Thank you
good.
again.
Okay.
Yeah, yeah,
Thanks,
yeah.
everybody.
Bye-bye.
Bye-bye.